Okay, we're going to go ahead and start. We're going to take a look at the digestive system today, at least part of it. And we have numerous models to look at on how things work. So let's go ahead and get us started here. Anybody have any questions on anything before we start this? Okay. Oops, there we go. Human digestive system. Let's go ahead. Now we can go forward. Okay. Our digestive system is often called the digestive tract or the alimentary canal. It's a 30-foot long tube, and it's considered outside the body, so it's all lined with epithelial cells because it's open at the mouth and at the anus. And we use smooth muscle contractions known as peristalsis to push food through the system from the time we swallow it to the time we release the waste product. We're going to be using smooth muscle. We are going to start the process of digestion in our mouth. We will continue in the stomach. We will continue in the first part of the small intestine, and then we absorb in the remaining part of the small intestine. And then whatever's left over, whatever we don't use, whatever we couldn't take, is going to be moving to the large intestine and then ultimately released as fecal matter. So.
Is that not working?
Oh, yeah, I got to bring that down. I'm sorry.
No, you're fine. I was just.
No, I got to turn the volume down though because. I don't like those little noises. So. Okay. Now, digestive processes involve what we call ingestion, where we actually eat the food. Thank you. The screen was acting funny. Actually take food into the mouth, process of eating. The movement of the material from our digestive tract. Gravity helps us some when we swallow into the esophagus, but after that, it's pretty much smooth muscle all the rest of the way. Digestion, as I said, starts in the mouth. We start breaking down starches using the saliva found in our mouth. The saliva contains enzymes such as amylase, which breaks down starchy carbohydrates into sugars. We start the process there. We swallow that, any kind of food we're eating. And there, even the process of grinding it up with our teeth is considered part of the digestion. And then the chemical digestion starts in the mouth too with the release of amylase. And then we move into the stomach. The stomach, popular misconception that food goes into our stomach and then goes everywhere in our bodies. Well, not really, because all the stomach does is give us another place to churn up whatever we've eaten, to break it down into to continue the process of breaking it down into the nutrients we want. We want the proteins, we want the fats, we want the carbohydrates. Oh, comment. Isn't that also amylase? Is that your question, Logan?
Yeah, it is.
Okay, I don't know. I've never heard it put that way, but I'll look it up for you. I've only ever heard of amylase as we know it's an enzyme, and it breaks down starches. Let me see what Dr. Google says here real quick.
My favorite doctor.
Yeah, excuse me. Okay. Let's see.
My favorite diagnostic. I go to the person.
It's better.
There we go. That's what I meant to say. You know, doctor doesn't answer your Google stuff. You're like, well, I guess I'm dying.
Yeah, you're done.
You know,
Okay.
that's how it usually goes.
I can't find anything that says, I'll have to look at a little further now. A quick look in Google didn't show anything, but that means nothing. So let me look into that and I'll try and find an answer for you. So, okay, now, so we mechanically and chemically break down the foods that we eat so that we can ultimately absorb the nutrients. Absorption takes place in most of the small intestine. Now, the first 10 inches or so of the small intestine, we're still processing. We're still tearing apart proteins. We're still chopping up fats. So we don't do a lot of absorption in the first 10 inches. After that, the remaining 19 or so feet of the small intestine is where we're going to absorb. We're going to absorb our nutrients. The simple columnar cells of the small intestine are lined behind them with sinusoidal capillaries and fenestrated capillaries, so that we can, the two big areas for fenestrated capillaries are going to be the small intestine and the glomerulus. The glomerulus is for filtering. Here, the fenestrated capillaries and even some sinusoidals are for absorbing. So, and then of course we have defecation, where we get rid of anything that is not digestible, usually the stuff that's high in fiber. We can't process fiber. Fiber, it comes from the outer covering of plant material, the outer covering of oat grain and corn and wheat grain. That's the bran, if you will. Like if you eat corn on the cob, you notice that the yellow covering of the corn kernel, you may notice that it shows up in the fecal matter. It doesn't get processed. Only the inner content is what we can process. It's just like eating whole wheat bread because it has the bran, the covering of the wheat kernel embedded into the flour, and you can't process that. That passes on through. These fibers, this bran material is a part of a healthy approach to eating, because the bran isn't digestible, but it does have a somewhat cleansing effect on the colon to get material out of the colon from having to accumulate. Now, some of the claims that you hear on the internet and are fairly ludicrous. They don't work, but there is a real benefit from fiber in the diet. That's my post on what to eat, because I like Cheerios, and Cheerios have oat bran, and bran is bran. Now, oat bran works on cholesterol levels, but it's still bran. It doesn't get digested. If you like whole wheat bread, if you like bran muffins, you're getting whole wheat. If you like beans, there's a lot of fiber inside beans. The fiber is indigestible material. So, okay. Now, our digestive system has two parts to it. It has the true digestive system from the mouth to the anus, all 30 feet of it. We have the mouth, the pharynx, which is the throat, the esophagus, the stomach, the small intestine, the large intestine, the rectum, and then the anus. The accessory structures that food does not pass through, but we still need, are the teeth, the tongue, the salivary glands, the liver, the gallbladder, and the pancreas. We need all of those to process the food as we're passing it through the digestive tract. Food doesn't pass through them, but they release material that's absolutely essential. This is where we're going to see the pancreas, for example, functioning as an exocrine gland, where it actually releases enzymes through its pancreatic duct, as opposed to functioning as an endocrine gland where it just secretes insulin and glucagon. Okay. Okay, thank you, Logan. I will. 6 times stronger than morphine. Save up your spit. So, okay. Let me look into that, and we'll talk. We can talk about that next week when we finish up this. I had no clue. Thank you. I'll be the first to admit I had no clue. So, okay. Now, our digestive system has generally 4 layers. We have an outer layer of connective tissue to hold it in place. We have 2 layers of smooth muscle as we move inward. We have a circular layer and a longitudinal layer. The circular layer runs in a ring around the alimentary canal, the digestive tract, and it squeezes inward from, it just squeezes. The longitudinal muscle runs lengthwise. It squeezes also, but it squeezes, if you can imagine, sort of like a flat squeezing, it's like putting your 2 hands together and pushing them together. That's what the longitudinal muscle does. But the circular muscle is squeezing in more discrete packets. We squeeze the contents of the digestive system with these 2 muscles to push them down from start to finish. This is where we get the term peristalsis. Think of the pig and the python, the bulge in the python where the pig is, and it moves down through the snake. Well, that's sort of what our digestive tract looks like, as the bulge from food is gradually pushed down and processed and absorbed. We don't have to do anything about it. We don't think about it. It's all autonomic muscle control. Now, moving further inward, we have the what we call the submucosal layer, which is connective tissue. And then we have the mucus layer, where we have stratified squamous epithelial cells, so that we don't wear those layers away. And we have lots and lots and lots of goblet cells to lubricate the passage of the food. And then we have the lumen. The lumen is the opening, the middle of the tube. And so we lubricate it extensively. We have stratified squamous cells, just like we had in our cheek cells. They wear away, they wear away. We keep making more and more and more. You can see in the other illustration here, over here in the pink side, that is stratified squamous, multiple layers of living cells that just wear away, because it's the passage of food through our mouth, through our digestive system, inflicts a certain amount of trauma on the tissue. So we don't care, because the cells there protect us. And we keep it good and lubricated. I don't know if we can see. Well, this looks like a lot of little goblet cells. There's like all those little white things are probably the goblet cells that we see right along in here, lubricating this extensively. Because, we don't want it to be painful for food to pass through our digestive system. We wouldn't eat, or we wouldn't eat very much. We'd eat a lot of soft things and nothing, very soft food items, if we didn't have some sort of lubrication going on in there. So the mucus layer, the inner layer, is where we have nothing but simple columnar epithelial cells. They are the absorbing cells of our small intestine, for example. And underneath that, again, we have the capillaries that absorb the nutrients. The submucosa is connective tissue that holds the mucus layer in place. Most of the action is going to take place with the mucous membrane. That's what we call mucous membrane. We've all heard that term before. This is actually what it means, is to have the mucous membrane here. So we absorb our nutrients here, particularly in the small intestine. We don't do a lot of nutrient absorbing in the colon. We do very little nutrient absorbing, if any, in the stomach. We do nothing in the esophagus or in the mouth. It's all going to take place in the small intestine. So Now, the muscle layers that surround our digestive tract are going to be smooth muscle. And they're going to be, as I said, a circular layer and a, move this out of the way here. There we go. And a longitudinal layer. You can see the circular layer is on the inside, the longitudinal layer is on the outside. By the way it squeezes, we can push anything through our digestive system that we want. Okay. So the stomach is a little different. Stomach has those two layers. It has a third layer called the oblique layer, because our stomach is a funny shaped organ. Our stomach is shaped like the letter J, if you will. And so it can constrict, it can churn, but it can churn in three different directions. It can churn, it has the two layers of smooth muscle. It has a third layer that runs at an oblique angle, so it can churn all the way around. Because we do a lot of interesting things inside our stomach. I have a spider crawling across my monitor. Okay, so.
You're gonna kill
No, not yet. So I'll save it. Now, the outer layer of the digestive tract is covered with serous membrane. Remember, the inside layer, the inside portion of the digestive system is really open to the outside. It's like a hose. If you look at a hose, the inner part, the inner part of the hose is open at both ends. That's the lumen of the hose, it's open at both ends. But the outer covering doesn't affect what's inside. Our small intestine is the same, our digestive system is the same way. The outer covering is within our body cavities. It's within the abdominal body cavity and the abdominopelvic body cavity, or the pelvic region here. It's the outer covering of the digestive tract is not exposed to the outside. So it's serous membrane. It is continuous with the peritoneum. The peritoneum is the serous membrane that covers all of our visceral organs. So all these structures that we see in the digestive system are internal. It's just the inside of it. It's open to the world, if you will. So instead of having mucous membrane, we have serous membrane. It's the same thing. Serous fluid and mucus are the same fluid. The cells are the same cells. They are epithelial cells, but we call them endothelial because they're internal. There's no difference in them. So we have serous membrane out there for one very good reason. We don't like friction. Serous membrane is continuous with the visceral peritoneum. The visceral layer of a serous membrane always sticks to the surface of an organ. There's a parietal layer that lines the inside of the cavity. Now, and there's this goopy serous fluid in between. Our digestive system moves around a lot. We can hear it sometimes making funny sounds as it moves. We get cramps, we get bloated, we make all these funny noises and sounds and churning noises and stuff like that, because it's moving. And when it moves, it's rubbing up against another structure in the abdominal cavity. Well, if there was no serous membrane there, we'd have friction, and friction hurts. And if it hurts, we don't do it. So we don't like that. So we keep the outside of our digestive tract as lubricated as the inside. We just don't like to have any kind of friction. We also hold these organs in place. Do you ever wonder why, when we look at a torso of the abdominal cavity, that everything's held there very nicely? We don't have the little hooks and screws like Mr. Cadaver does over there with his abdominal cavity hanging out. How do we keep everything in place? We have lots of connective tissue that holds these organs where they belong. We call it, one part of it's called the peritoneum. peritoneum is a layer of serous membrane, which part of it adheres to the surface, inside surface of the abdominal wall, and the other part is stuck to the organs themselves. And we have structures called mesenteries, which are extensions off of the peritoneum that help hold our organs in place too. Like what you see here, these tissues here are the mesenteries. What you don't see are the visceral and parietal peritoneum. Visceral always refers to a covering on the organ. Like remember the visceral pericardium on the heart? That was the lining that stuck to the surface of the heart muscle. And then we had the parietal pericardium, which formed the outside of the sac, or the lungs. The lungs have a visceral and parietal pleura, to reduce friction. Well, here we have the peritoneum. But we also have the mesenteries to hold everything in place. And this holds our organs in place so that we do indeed look like, Mr. Cadaver over there. Okay, starting at the mouth. When we eat something, we start with our mouth. We start usually chewing it with our teeth. We manipulate the food with our tongue. We use our teeth to mechanically break down the food. Our tongue moves the food around and gets it coated with saliva so the process of digestion, the chemical digestion can start. And it also tends to form our food in the shape of a little ball called a bolus. That little bolus is what we're going to swallow. So we start this whole process right away. Doesn't matter what we ate. So we mix the food with saliva. We have 3 different sets of salivary glands. We secrete a tremendous amount of saliva when we eat, and we use it to lubricate the food and chemically break it down. We want to lubricate it so it doesn't hurt to swallow it down our esophagus. So the salivary glands are the parotid glands. These are big glands right in front of our ear, directly above the mastoid process on the side there. We have the submandibular glands, which are under the tongue, and the sublingual glands are under the tongue, and submandibular are under the mandibles. So saliva that we release is mostly salt water. 99% maybe salt water with sodium and potassium, a little carbonic acid in there. It's slightly acidic. It contains salivary amylase and lingual lipase. Amylase breaks down carbohydrates. Lipase begins to break down fats. It contains mucus. That's where the mucin comes in. It also contains lysozymes to attack pathogens. It contains what's known as the IgA antibody. That's usually the first antibody we release when we have any kind of pathogen present. It has what are chemicals known as defensins, which can break down bacteria, and it even contains a little bit of cyanide. So we have lots of things to protect us, because after all, the mouth is one of the great entry points for pathogens into our body. The mouth and the eyes. Skin, not so much. If the skin's intact, then things aren't going to get through the skin. But if the mouth, we take stuff, ingest stuff, or we rub our eyes, so that's how we get pathogens to, hey, come on in. Okay.
Yeah, I didn't know you could you get sick
Oh yeah.
Yeah, I didn't know that until COVID.
Yeah, you can, because it is there is a well lubricated fluid there in the eye, but if you rub your eye and your hands are infected with a pathogen, then that's a good route of transmission too. So even though the tears have their own antimicrobial properties, not so good in viruses. So. Okay, so here's the location of the salivary glands. We have the parotid gland. A big gland sits right in front of the ear above the mastoid process. We see the submandibular gland down along the side of the mandible, and the sublingual gland is underneath our tongue, because you can see the tongue is sticking up here. There's the sublingual and there's the submandibular gland. So these three big glands here are going to lubricate our food. So, and this is what the parotid gland looks like on, this is its real location. It's like if you come to the earlobe and go just in front of the earlobe and straight down along the side of your face, that's where your parotid glands are located. Now, the mouth and the esophagus and the esophageal sphincter, the mouth is the oral cavity directly below the nasal cavity. The hard palate of the mouth forms the floor of the nasal cavity. The throat, the pharynx, is open to the nasal cavity that we call the nasopharynx, which is the back of the nasal cavity here, is continuous with the oropharynx here, which is continuous with the laryngopharynx here. This long tube is the pharynx, but it has three distinct regions here. And when we swallow, the tongue forces a bolus of food to go towards the larynx. When we swallow, the epiglottis here will immediately close over the opening to the glottis. The esophageal sphincter will open so that food can go down into the esophagus, and the uvula will swing up, and uvula and the soft palate will swing up and close the opening to the nasal cavity. And this is something, it's a reflex. We don't think about it. And this cabinet door, oops, opening. Okay, so the esophagus is normally flat. It does not stay open. The trachea has a series of cartilage rings in there to keep it open all the time, but the esophagus tends to stay flat. It's only when food goes into it does it become enlarged. And we guard the opening to the esophagus with that esophageal sphincter. Part of the reason too is we don't want to inhale air into our stomach, because then the stomach gets bloated. So the sphincter keeps the esophagus closed. There's a close-up of the oral cavity. We see the hard palate, that is the palatine process of the maxilla and the palatine bone. We see the tongue. You can really see all of the, I should have shown this to the AP ones. We were doing taste buds yesterday. You can really see the papillae where the taste buds are located here. We see the soft palate. We see the uvula. Their big role is to close off the opening to the nasal cavity when we swallow. Here's the epiglottis, which closes off to shut down the opening to the glottis right here, the airway. And there's the esophagus, and just get a hint of the esophageal sphincter right in here. Now swallowing is voluntary. We push food to the back of our oral cavity and we swallow it. It's a voluntary action. We don't have to swallow. But when we do swallow, we have a couple of reflexive actions. One is to open the esophageal sphincter. The other is to close off the airway, usually. And so we send a little bolus of food into the esophagus. And we have, the esophagus has the same 4 layers that we see, that we encounter in the small intestine. Mucus, submucosa, muscle layers, and connective tissue. This is the process of swallowing. The esophageal sphincter opens when the epiglottis closes. So whatever they're swallowing here, you can see the epiglottis sticking up very prominently right here. And there's the glottis, the opening to the trachea right there. The esophagus is between the trachea and the spinal column right here. There's the esophagus, this white area in here. And whatever they're, I suspect it's some sort of radio opaque dye that they're putting in, they're giving them maybe something like barium or something equally unpleasant. And if you look carefully, you can notice how the uvula kicks up and closes off the entrance to the nasal cavity as we swallow. So a lot of stuff going on here just to swallow. And so usually, if we're dealing with solids, it's just a little ball of food. We call it a bolus. So there's our oral cavity. You can see the uvula and the soft palate, or as we like to say, the little dangly thing that hangs down in the back of your throat. Because you don't get very far by saying things like uvula, especially in Tennessee. But
What you trying to say? What you trying to say?
I've lived here for 18 years.
So
I
you're
can.
talking to yourself.
I'm talking to myself. Yeah. Anyway, soft palate and the uvula do a very good job in closing off the entrance to the nasal cavity. The palatine tonsils are found on either side. The tonsils are part of our immune system. They're designed to become infected. That's what they do. They're sacrificial in nature. The tonsils form a ring around the opening to the airway. And that's their role. When we talk about the immune system, you're going to see that the tonsils are designed to become infected. Their very structure is designed to trap bacteria deep inside these cavities called crypts. And so the bacteria can grow there, and that will trigger a response from the overall immune system. That's what they do. They often become inflamed, which is why for years people have always had many people have had their tonsils taken out or not. Anybody who still has their tonsils here?
Really?
Yeah.
I get tonsil stones. So bad.
Mm-hmm. I used to, but is that what causes tonsils stones? So it could be, because tonsils get infected, and when they have these ulcers and sores there, it can cause those kinds of problems, I would think. When we get into the immune system, I've got some really nasty looking infected tonsil pictures. We've all had sore throats, and if you still have your tonsils, you know.
Don't have them, so it's sort
Oh,
of-
yeah, you do, but it seems less painful.
Yeah.
I would, it would seem less painful, because when you have a really bad sore throat, the feeling is like swallowing razor blades. All 5 of them at a time. So okay. Now, here we see the tongue. We see the ducts here of the salivary glands there and there, and we don't see, I guess these doesn't see where the duct is on the parotid gland. So anyway, now let's take a look at some of the structures here in our mouth. We generally have about 32 teeth. We start out early in life developing our milk teeth, or our deciduous teeth, or just plain old what we call baby teeth. And they start coming out at 6 months. He's cutting a tooth, she's cutting a tooth. We know how unpleasant it is for children that young to deal with that pain. But they generally last till about 12 years of age. We only get about 20 of them. We don't get all 32. So they fall out somewhere around between 6 and 12. Our permanent teeth come in, and you can see in the x-ray here, the deciduous teeth are here, and we can see the permanent teeth coming out behind them, and they're actually pushing the deciduous, the milk teeth, the baby teeth out. And so they fall out, they drop out. We've all seen kids, pre-adolescent kids with their front teeth missing. It's because their permanent teeth are pushing them forward. We generally get all of our teeth by adolescence, and then our third molars usually come in last. And they can cause us trouble. There's no guarantee that they're going to come in the right way, because sometimes they come in sideways, and that always creates a challenge. So, yeah. 3 different types of teeth. Incisors. They're the ones in front. They're the cutting and biting teeth. You bite into an apple, you use your incisors for that. You know, you're eating a carrot or whatever, you're eating any kind of fruit. You're going to cut into the food with the incisors. On either side of the incisors, we have the canines. They look like fangs. They're pointed. They are for ripping and tearing. So like you're eating barbecue and you off of a rib, and you are biting biting into the meat and pulling it off the rib. You'd use your canines for that. Behind the canines are the premolars and the molars. The old name for the premolars are the bicuspids. They are for crushing and grinding. You're eating vegetables, you're eating peanuts, you're eating any kind of plant-based material, fruit or vegetables, you're grinding it up. It's not the ripping and tearing like you would eat meat, for example, with your canines, but the ripping and tearing is taking care of the canines, and the crushing and grinding, particularly on any kind of grain product or fruit, something like that. Now, how many do we have? Well, 32 teeth, 16 on each jaw. We have 4 incisors in the front. We have 2 canines, 1 on either side of the incisors. You can see where here are the incisors across the front. The incisors look, they have like a shovel, a shovel-like shape, flat on the end, and they look like you could use them to dig with, because you're going to be biting into, different foods. On either side, you have the canines. The canines are these pointy, fang-like teeth, your vampire teeth, if you will. Then behind them, behind the canines, now this is on both the mandible and the maxilla, you have your premolars and you have your molars. Now you have 2 premolars here and here, and then 3 molars. Your third molar is what we call the wisdom teeth. Now, and they're the ones that come in later, because you see the first and second, look at the age when these all show up. The premolars show up at 11 and 12 years of age. The molars show up somewhere between 6 and 13, but the third molar, the wisdom teeth, don't show up until late adolescence, early adulthood. And because they're not coming in when the other teeth are, they may come in crooked. Instead of growing up like it's supposed to, it's not uncommon for them to grow this way, or this way, or this way, or this way. They can come in sideways.
That's why they just go ahead and usually just.
And that's why they have to take them out.
Yeah.
If they come in fine, no problem. If they don't, then you have to have them cut out. So, and that's because they're not coming up to the surface of the bone like they should. So you have to have them removed. So many people do, many people don't. So anyway, so we have 32 teeth on each jaw. We have 4 incisors, 2 canines, and we have 10 molars and premolars altogether. 4 premolars and 6 molars. So now the tooth is a pretty interesting structure here. The crown of the tooth is the exposed white portion covered with enamel. We call that, that's the crown is above the gum. The gum is called the gingiva, and the gingiva is this area right here. There's enamel, there's dentin, more enamel. pulp canal, pulp cavity, roots. There, up. There we go. There's the gingiva. Of course, the last thing I was looking for. The gingiva is the gum. Now, the enamel is the hardest structure in our bodies. It is made up of calcium and phosphorus crystal salts, salt crystals in here. It's very, very strong, but it can be degraded by bacteria. So that's the strongest portion, strongest substance in the body is the enamel. The second strongest substance in the body is directly underneath it, the dentin. And so the dentin forms that area right underneath the enamel. The tooth is alive when we get into the lumen, where we have the blood vessels and the nerves in the roots and in the pulp cavity and canal. So this is all a living tissue in through here. Now the outer covering is not, it's all made up of, dentin and enamel, but this is the living tissue in here, particularly in the root. And this, of course, is the infamous root canal that goes out to the, the root canal provides a passageway for the blood vessels and nerves to lead to additional vessels down in the mandible coming through or the maxilla coming through some sort of foramen. So the root is embedded in the gum, in the mandible or the maxilla. And the root is attached to the crown by this structure called the neck. And this is the neck area right in here. So it's a pretty, our tooth is a lot more complicated than we think. Now this little white band that we see here, this is a ligament. This is called the periodontal ligament. And that's what holds the tooth in the socket. If you've ever had a tooth removed, one of the things that you hear the dentist say, hopefully after they've anesthetized your gum, is that now you're not going to feel any pain, but you're going to feel a lot of pressure because you have to pop the tooth away from that ligament. That ligament is holding the tooth in. And so what will happen is there'll be a very distinct, usually a distinct popping sound. You'll definitely notice when the tooth gives, when it comes out of the socket. But because that ligament is very powerful to hold it in place there. Now, we use a glue called cementum to hold the tooth to the periodontal ligament. Let's see. Dentin is underneath the enamel. Dentin is replaced. We can grow back dentin. We use what are known as odontoblasts to make the dentin. The dentin is supplied by nutrients and nerves, and everything runs through the root canal. The canals themselves to send blood vessels and nerves up into the pulp area. So there's another. This is a canine tooth here. Again, showing the crown and the neck. You can see where the neck is embedded in the gum line itself. The enamel covers the dentin. We have the pulp cavity. We have the gum. We have the cementum attaching to the periodontal ligament. And this whole structure here is the root canal. So, which is just a canal. That's all it is, just a canal. But the nerves and the blood vessels pass through that. So now gum disease, tooth decay and gum disease, a very significant problem everywhere. The term for a cavity is called a dental caries. The bacteria that live on our teeth release digestive enzymes and acids that dissolve away the enamel. This is what the surface of a tooth looks like after brushing. Yeah, it's surprising how much bacteria remains even after cleaning, the bacteria will gradually eat away at the enamel. And if they get far enough, they'll eat into the dentin. They form a substance known as plaque. The bacteria form something called plaque, not like the plaque that accumulates in our arteries, but this plaque contains lots of sugar. It contains, the bacteria live in it. They have tooth debris. They have debris from other foods, and they dissolve the enamel. And they also attack the gum. So not only do we have a problem with the tooth becoming decayed, but if your patient has poor dental hygiene, they also are probably going to have their gum inflamed too, a condition known as gingivitis. So this is dental caries, cavities. You can see some really nasty looking decay going on here. You'll notice that this tooth is pretty much gone. This one's probably gone. This one's probably gone too. You also notice how inflamed the gum line is. So the bacteria, the plaque that was growing on the teeth, the bacteria are also releasing enzymes which attack the gingiva. And so now we have inflammation in the gingiva. We call that gingivitis. And while some of these teeth may look fairly clean, they're not. You know, there's a lot of plaque accumulation at the base of all these teeth here, and this area is really suspect right in there too. But you can tell that dental hygiene has not been a priority for this individual. So here we see an example of gingivitis itself. Now this is gingivitis with significant inflammation. The teeth don't look bad. The teeth look white. You know, we like our teeth to look clean, but the tartar that forms between the gingiva and the teeth cause inflammation. It's an anaerobic bacteria, meaning it doesn't require oxygen. It grows in an oxygen poor environment. And so the gums are attacked, and you can see, you know, they're inflamed, they're bloody. When a person brushes their teeth and they have a lot of blood coming out when they're brushing their teeth, that's an indication of gingivitis. Now you can treat it. It's reversible as long as they stay after it. They stay with it. So, okay. Problems. Another problem here. Periodontitis. Periodontist is a dentist. This is periodontitis. It is an inflammation of the periodontal ligament and the bone destroyers. It's an inflammation of the ligament and turning on osteoclasts. You remember osteoclasts are the bones with lots of lysosomes, and they dissolve away bone for us to get calcium. Well, here with periodontitis, the immune system will attack the pathogens that are found on the teeth, but that also ends up resulting in destroying the ligament and destroying the bone. We see the bone dissolving away here. We lose the tooth. We lose the gum itself. The mandible or the maxilla is dissolved away, and the infection that's triggering this immune response may spread to the heart. And it sounds ridiculous to think about it, but a person may develop heart disease or may die from a gum infection. And so it may trigger infection in the periodontitis can trigger infections that are going to cause coronary artery disease, clot formation, and sudden death. So it's a concern, because that bacteria that is present there can migrate itself, particularly to the heart valves too. So, okay. On that cheery note, we're going to go on to the esophagus. The esophagus is about 10 inches long, 8 to 10 inches long. It is lined with stratified squamous epithelial cells, and because we want to have them wear away. And it has a smooth muscle layer to help push food down into the stomach. It is guarded at its lower end by a ring of muscle called a sphincter. It's called the cardiac sphincter, which guards entry into the stomach. Unfortunately, that sphincter can be pushed the other way too. So you can see the esophagus goes from the back of the oropharynx, or actually from the larynx down to right here. There's our stomach sitting right there. It is described as a J-shaped organ. Now the stomach has 4 parts to it. It has the areas are known as the cardiac region, the cardiac region, the fundus, the pyloric region, and the body. There is a sphincter at the cardiac region called the cardiac sphincter, which controls access to the stomach from the esophagus. The fundus is the large curve in the body of the stomach. The pyloric region is down near the entrance to the small intestine. We have a sphincter there called the pyloric sphincter, and then the body is the area on the inside, on the curve of the stomach. Now, food comes in through the cardiac sphincter, comes in there, and it is churned. But first, the food, when it comes in, goes to the fundus. Now, the fundus region, let me show you up here. There's our stomach, duodenum. Cardiac sphincter is right there. Pyloric sphincter is right there. There's the fundus. There's the cardiac region, the body, and the pyloric region right there. Lesser curvature, greater curvature. Longitudinal muscles, circular muscle, oblique muscle right there. Now let me go back. Okay, now, so when we eat something, food moves into the fundus immediately because there may be amylase there. Amylase breaks down carbohydrates. The carbohydrates, amylase can't function in the stomach because the stomach is operating at about a pH of 2. Amylase is designed to operate at about pH of 7.4. Amylase works at the level, the pH level of our mouth. So amylase has to be sort of parked in the fundus so that it isn't destroyed before we can use it, before it finishes its job. Now let's take a look at this. And okay, this is that's okay. It's fine. So okay, we have a life-size schematic model here of the digestive system, and now there. This is our stomach right here. This is the esophagus coming in. Let me see if I can turn this better for you. There, this better. Okay, now there. here's our esophagus coming down from the pharynx. Here's the oral cavity up here. There's the oral cavity right here. There is the esophageal sphincter right here. There is the epiglottis guarding the entrance to the glottis. There's the uvula, and there's the soft palate right there. There's the tongue. Now, if we come down here, we can see there's the esophagus. Now, the esophagus is nothing more than essentially a hollow tube lined with smooth muscle and stratified squamous epithelial cells. We get down here to the stomach proper, and this is the cardiac sphincter right here. This protects the stomach from food that comes down here, and food enters here at the cardiac sphincter. Now, this is the fundus area over here. Carbohydrates move over here to park there to give the amylase time to function, because the pH inside the stomach is around 2 because of the hydrochloric acid present. Amylase is an enzyme. Amylase only functions at 7.4. It's destroyed at 2. So we pull any carbohydrates move into the fundus so that they have time to finish being digested by the amylase. We move down through the stomach, down here to the pyloric sphincter. This guards the entrance to the small intestine. This is the opening to the small intestine right here. And we see that this is the pancreas right below the stomach. Note the ridges on the stomach here. The ridges are called rugae. And what the ridges do is increase the surface area for processing material. And when we churn the inside of the stomach, we expose the food that's in the stomach to all the chemicals in here, and to continue the process of chemical and mechanical digestion by the churning action. What comes in sort of resembles what we swallowed. What comes out looks like something that has the consistency of condensed soup. Like cream of, ever see a can of condensed cream of mushroom? You take it out.
Thanks for moving it. I'm just kidding.
How about cream of chicken? Is that better?
Yeah, because I won't make that.
Okay, so it looks like a can of cream of chicken soup, even though it looks like cream of mushroom. The condensed, how it comes out of the can, it's that thick, goopy, pasty-like material. That's what it looks like by the time it gets to here. We call it chyme. See, I'll show it on the CHYME. It's a very thick, pasty material that is essentially squirted through the sphincter into the duodenum. So now let's see this. Anyway, I'll figure that out when I get to the next part. So,
It's a short one.
it's very interesting. I've never had to deal with 3 cameras before. Okay. Now, so there's our stomach. There's the model of the stomach we have on Cadaver Guy over there. And you can see there's the pyloric sphincter up here. The cardiac sphincter right there. It's just a ring of muscle between the esophagus and the entrance to the stomach. There's the esophagus there. There's the duodenum. That's a short segment of the small intestine where we finish the process of digestion. Proteins are finished being digested in the duodenum. Fats are chopped to pieces in the duodenum and absorbed there. Our carbs have already been absorbed or are ready to be absorbed as we move into the small intestine. So now there's the cardiac sphincter right there. This area up here is called the fundus. There's the pyloric sphincter at the other end. The fundus, where we park the carbs. The cardiac region, the body, and the pylorus region. We have what's known as a lesser curvature It's the inside curve of the stomach, and the greater curvature, the outside curve of the stomach. The stomach is designed to do what it does. It's designed to churn food around in here so that all the contents of the stomach are covered with digestive enzymes and covered with hydrochloric acid to help to break down protein, to help to finish the process of digestion, which we end up completing in duodenum. So lesser curvature, greater curvature. We also have 3 layers of smooth muscle. We have the longitudinal layer and the circular layer, just like we have everywhere else. But here we have an oblique layer. That's what's bending down across at the angle there. There's the circular layer, and there is the oblique layer there, so that we can churn in 3 different directions in the stomach. Again, a close-up of our stomach model. This is about life size. It's about 6 inches across. You know, it sits on the left-hand side of our abdominal cavity, directly underneath the diaphragm. On the liver is on the right-hand side. And just for perspective, I'll just show you how big the stomach actually is. Let me get out of this and get back to the camera. So you can just see how big a stomach really is. You know, this is about life size, you know. Maybe 10% smaller, but on the
It's not
average,
big.
no, it's not very big. None of our organs are very big. You know, consider the size of our kidneys, little tiny things, you know, so.
So no wonder we go miserable when we eat too much.
Oh, yeah. So, because, you know, when we eat a lot and we end up stretching our stomach, that, you know, that does create a lot of pain.
Yeah.
And discomfort. To say, okay, so there is our, let's move you out of the way. There's our stomach. There's the esophagus, the duodenum, the cardiac sphincter, the cardiac region, because I guess because it's closest, it's very close actually to the location of the heart. I guess where the term cardiac region came from. The fundus is the top bulge of the stomach, the body, pyloric region, lesser curvature, greater curvature. And we have our layers of muscles, and we also have these structures here called rugae that form, the mucus layers form ridges. The mucus layers are forming these ridges inside the stomach. The rugae are what increase the surface area for processing of foodstuffs. And so like, that's a rugae. It's a bulge inside the stomach. All those ridges that I showed that you can see here on the stomach are the rugae. And all they're there is to increase the surface area so that we can have, we can process food. There we go. There's our, these are all the rugae right along in here. You know, increasing, every one of those ridges increases the surface area for processing the food. Let's get this out of the way. So what's it look like on the inside? Well, here's our 3 layers right there. There's our rugae. This is a stomach that's been opened up. And they all look pretty much the same with a sphincter in each end. Both sphincters are designed to restrict the flow of material. It's the cardiac sphincter that gives us the greatest problem, because that's the one that is failure of that is what causes acid reflux, or what we call gastroesophageal reflux disease, or GERD. You know, overeating, overproduction of acids in the stomach, we get a regurgitation up the esophagus, which burns the lining of the esophagus and it damages the esophagus. It may all the way up into the throat, but this is where acid reflux comes in because the cardiac sphincter fails for whatever reason. Yeah, let's see. Okay. Now, internally, there's the rugae again. Gastroesophageal sphincter or cardiac sphincter, pyloric sphincter. So what's inside the rugae that makes this thing work? Well, the stomach is lined with columnar epithelial cells, simple columnar cells. And within those cells, we have gastric pits. And in the gastric pits, we release something called gastric juice. And there are about a half a dozen different types of glands present in these pits to make the gastric juice. And so we're moving the food all the way around here. Simple columnar epithelial cells. One thing that they do well, though, is they secrete lots and lots of mucus. And the mucus is alkaline because the stomach produces hydrochloric acid. And you don't want hydrochloric acid being released with a pH of 2 into your stomach. So we try to neutralize it with mucus. So now, okay, 5 types of cells within the gastric glands. We have what are known as chief cells. Chief cell, you need to remember these. Chief cells secrete pepsinogen. Pepsinogen is the inactive form of pepsin.
So is that why they call it Pepsid, to like help?
Yeah,
That's a,
Pepto-Bismol and pepsin. Because of pepsin is here. Now, pepsin is activated when it's exposed to pepsinogen is converted to pepsin when it's exposed to hydrochloric acid. So we secrete pepsinogen, the inactive form of pepsin. Now, our bodies are very clever about this. We usually always see a 1 or 2 step process to get something made. Like when we're making angiotensin 2, we got to take renin and activate angiotensinogen, which activates angiotensin 1 to make angiotensin 2, which releases aldosterone. Like fibrinogen is activated by thrombin to form fibrin, in clotting. But thrombin started out as prothrombin, which then became thrombin, which then activated fibrinogen, which activated fibrin. So here we have pepsinogen being activated by hydrochloric acid to make pepsin. Pepsin is what we use to break down proteins, to release the amino acids. So the chief cells secrete pepsinogen. The next set of cells are called the parietal cells. They secrete hydrochloric acid, which is used to activate the pepsinogen. They also secrete intrinsic factor, which allows us to absorb vitamin B12. And because we got to have B12 or we develop pernicious anemia. The next set of cells we have are the goblet cells and mucus glands. The mucus is heavily alkaline to neutralize the hydrochloric acid. It lines the wall of the stomach. So we have this thick layer of mucus neutralizing the stomach acid. It gets there, otherwise the acid would eat right through the wall of the stomach. Even though the cells are held together with tight junctions, they're not acid proof, but the layer of mucus makes them acid proof. Otherwise we'd have bleeding ulcers all the time in our stomach. Now, we also have what are called enteroendocrine cells that produce gastrin. Gastrin helps us in the whole process of digestion. Now, those are the 5 types of cells. And on top of all this, the 6th cell are the stem cells that make all the other 5. stem cells are sort of like the fix it all the time cells. Stem cells can be whatever you need them to be coming on, like you have one stem cell for blood cells and you can make all 5 white cells, the red cells and the platelets. You have stem cells in the ovaries and in the testes that will make the gametes. Whatever we need, the stem cells will make. Well, we have stem cells that will make all 5 of these other cells here. So chief cells make pepsinogen, which becomes activated to pepsin when exposed to hydrochloric acid. Parietal cells make hydrochloric acid. They also make intrinsic factor. Goblet cells and mucus glands make mucus. Enteroendocrine cells make gastrin, and stem cells make the other ones. So now the pits look like the glands look like this. This is a gastric gland, and they have these pits that run down deep inside the lining of the stomach, and we have our parietal cells, our chief cells down here, our gastric gland cells here, our mucus cells here, and our endocrine cells down here at the bottom. So this is what the stomach is lined with, these pits, and within the pits we have all these different glands, all these cells that make these different substances for us. Stomach has 3 layers instead of 2, as I said. And we churn everything around and we produce this substance known as chyme or chyme right there. That's what's going to enter the small intestine through the pyloric sphincter. Here's a close-up of the gastric glands and the pits. You can see all the different pits down inside. Here's the pit, and we can see what the glands are doing, or where they're located, at least down here. So, okay. Mechanical production and chemical production takes place in the stomach. The chyme is produced by the pushing and shoving the food around and mixing it with the gastric juices, the acids and the pepsin and the intrinsic factor, and we end up with this goopy mess called chyme, which has the consistency, like I said, of condensed soup. Pepsin starts, once pepsin is formed by the hydrochloric acid, when pepsinogen is exposed to hydrochloric acid from the chief cells, then it starts breaking down protein. It has to stay at a pH of 2 to do that. We don't absorb most nutrients in the stomach. What we do absorb in the stomach is water and glucose and salt and alcohol and any drugs that are fat soluble, like, for example, vitamin E is fat soluble. Vitamin K is fat soluble. Vitamin A is fat soluble. Any fat soluble medications can be absorbed here. But proteins and fats are not absorbed in the stomach. So, problem. What if we don't have enough mucus on the wall of the stomach? We can develop an ulcer. Gastric ulcers develop in here. Gastric ulcers are not caused by stress. Gastric ulcers are caused by a bacteria called Helicobacter pylori. It's treated by an antibiotic. If you take aspirin a lot, or ibuprofen a lot, if you take Advil, a lot of Advil, your patient takes a lot of Advil, they can inflame the stomach lining, and that can lead to an ulcer. Because if you take away the mucus layer, you can then, without the alkaline mucus, the hydrochloric acid can start eating away, and then you end up with this ugly looking little ulcer here, which if it eats far enough away through the tissue, it can hit the blood vessel layer, and then you have a bleeding ulcer. Now, yes. Thanks for sharing that. Yeah, it's an unpleasant disease, and for years people treated it like it was like I'm going to eat raw eggs and drink lots of milk to get over my ulcers. Well, that's not the cause of it. Or I'm going to go get a fish tank and look at fish and think of pleasant thoughts. It's driven by bacteria, and it is, an unpleasant condition. So, and so this is a gastric ulcer in the pyloric region of the stomach, right here. Lots of people self-medicate with Advil or aspirin. Both of those are going to irritate the lining of the stomach by breaking down the mucus layer, which can lead to this type of infection. It's not going to say it will always do that, but it can lead to it. Or it just happens. So, okay. And what will happen is if the ulcer is not treated, then it can, if it's not treated and given a chance to recover, it will dissolve away the tissue until we get into the hypodermic layer of the tissue, where we find most of our blood vessels, and then we can bleed. Let's see, another problem. It's called the hiatal hernia. Lots of Americans have hiatal hernias and don't know it. It is a tear in the diaphragm that allows usually the stomach or a portion of the stomach to penetrate through the diaphragm. This is a major contributor to gastroesophageal reflux disease. The stomach is pushed up through this opening and is partially trapped. This is a hiatal hernia right here. Many people develop hiatal hernias through, a violent sneeze or a very powerful, very aggressive cough. They've got some sort of like bronchitis or something, or they strain themselves picking something up and they tear a little hole in the diaphragm. It says up to 80% of the population can have a hiatal hernia and not know it.
I do not know if it's not painful.
In some people, it may not be, or they don't think about it.
Yeah, they're just still in pain.
Yeah, and they don't understand like, okay, but it's because it traps the stomach, a portion of the stomach above the diaphragm. It leads to, particularly where the cardiac sphincter is, it allows the passage of stomach acids to move up into the esophagus. That's what esophageal reflux disease is. It's burning the esophagus. You are regurgitating stomach contents up into the esophagus, and it occurs. A hiatal hernia is a major cause of this. So, heavy lifting, bending over a lot, hard coughing or sneezing, violent vomiting, straining during defecation, the Valsalva maneuver we talked about in respiratory, where you hold your breath and you compress the rectus abdominis muscles, and you raise the pressure in here. You're holding your breath, and that puts pressure on the diaphragm, and that can tear a hole in it. And plus, older people, particularly that are obese, can, because of the extra body mass they're carrying, can also have a hiatal hernia. And of course, gastroesophageal reflux disease, acid reflux, heartburn, what we used to call heartburn, the regurgitation of the stomach contents into the esophagus. We damage the esophagus because we're bringing up pepsin, which is an enzyme, and hydrochloric acid. The lining of the esophagus can't deal with that. It becomes burned. It burns the stomach because it's like having hydrochloric acid dripped on your hands, pH like battery acid. once GERD starts, it has to be treated continuously. Because there are some long-term complications if you let it get out of hand. So, and it looks like this. Yeah, we have a healthy stomach, but when the reflux opens and the contents come up here, we see this is a normal esophagus here, but this is what it looks like after it's been burned by the stomach contents. All this red area and redness are inflammation caused by the movement of the acids and pepsins up into the esophagus. Okay, we are at a good place to stop now. I said we wouldn't get through all this today. So we're going to stop with GERD, and hopefully no one's going to go home and have cream of chicken soup out of a can tonight. So okay. So anybody have any questions on any of this? Okay, then I'm going to get us out of here, and I'll see you all next week. Yeah, next week. So next Monday.